Welcome in, everyone. Let's get right to it. Mastering vascular intervention coding can sometimes feel, well, like trying to decipher a completely secret language. But today, in this explainer, we're going to cut right through all that confusion. We are going to master stent placement coding guidelines together by grounding all those complex numbers and rigid rules into physical reality. We're translating the actual surgical steps into the exact CPT codes you need using a super clear visual structure.
Okay, let's dive into this roadmap. We're going to break down this heavy cognitive load into an easy-to-follow funnel. First, we'll answer, what is a stent? Second, we'll look at bundled versus separate procedures. Third, arterial stent codes. And finally, venous stent codes.
All right, Section 1. What is a stent? Before we even think about tackling the numbers, we really need to establish the physical foundation of what's happening in the operating room.
So a stent isn't just some random tube. Think of it as a slender wire mesh acting as a crucial piece of internal scaffolding. Its primary job? To hold an artery or vein open when a standard angioplasty alone just isn't enough to get the job done. Now these can be bare metal, or they can be drug-eluting, which simply means they're coated with a medication that slowly releases over time to keep that vessel from narrowing again. And what is truly amazing about this physical scaffolding is that over time the body's own cells will actually grow right around this mesh to keep it permanently in place.
To code this correctly, you absolutely have to visualize how the device is deployed. Step 1. The physician places a guide wire to navigate to the exact site. Step 2. A balloon is inflated inside the stent to physically expand it. And Step 3. The mesh is fully deployed, creating that necessary pressure against the vessel wall. Now, why do we care so much about these physical steps? Well, establishing this foundation sets up the exact logic for why certain actions are automatically bundled right into the final billing code. And that logic brings us to a massive, flashing warning sign. You know that balloon inflation we just talked about in Step 2? Listen closely. Balloon deployment of a stent should absolutely never be coded as an angioplasty. It is strictly the mechanical mechanism used to just open the stent. It's already part of the package deal, so do not use that balloon inflation as an excuse to bill for an extra angioplasty. Just don't do it.
Moving on to Section 2. Bundled versus separate procedures. This right here is the core conflict of coding vascular interventions. We're figuring out what belongs in the combo meal versus what is billed a la carte.
And this brilliantly illustrates exactly what we're talking about. It's a perfect cheat sheet. In our combo meal bucket, we have everything included in your primary stent code. That's the angioplasty in the same vessel, pre- and post-dilation, closure devices, and related imaging. You do not bill these separately. But over in our a la carte section are services like intravascular ultrasound, ultrasound guidance for vascular access, mechanical thrombectomy, and thrombolytic infusions. If the physician performs these specific services, they actually earn their own separate codes.
Now, what happens when a surgeon places more than one stent? The math here relies entirely on vascular geography. If you have multiple stents placed within one single artery or vein, that equals one code. What if you have a single long stent bridging across two vessels to treat a lesion? Still just one code. But if you place separate stents in completely different arteries or veins, you code each one separately. So the coding scaffolding depends heavily on the specific geography of the blood vessels. Let's clarify a highly specific rule regarding aneurysms. If a stent is placed just to act like a cage, literally just keeping embolization coils from washing away, do not code the stent separately. It's completely bundled into the embolization procedure. However, if there are no coils at all, and the stent itself is the only embolization treatment used, well, then you do code the stent placement. Basically, the stent's primary function dictates the code.
All right, Section 3, arterial stent codes. Let's drill down into the specifics, starting our journey with the arteries.
Let's move to and see how this builds with codes 37236 and 37237. Code 37236 is your primary procedure code for the initial artery. Notice how it explicitly includes the angioplasty and the imaging right there in the description. Now, if the physician stents a second separate artery during that exact same session, you use the add-on code 37237 for each additional artery.
But hold on, there's a major exception here that you absolutely must treat as a giant stop sign. Do not assign 37236 for stent placement in a lower extremity artery for the treatment of occlusive disease. Arteriosclerosis in the legs actually has its own specific set of codes. But keep your critical thinking caps on. If you are placing a stent in that same lower extremity for treatment of a dissection or as an embolization device, then yes, 37236 is back on the table. It is all about the diagnosis.
And while we're talking about exceptions, let's quickly rattle off the anatomical red flags where these specific arterial codes simply do not apply. Never use 37236 or 37237 for stents in the cervical carotid arteries, extracranial vertebral arteries, intrathoracic carotid arteries, intracranial arteries, or coronary arteries. Those regions have entirely different coding pathways, so definitely keep this exclusion list handy.
So the crucial point is what you do when the procedure is bilateral. Imagine the physician stents both the right and the left renal arteries. Your instinct might be to use a modifier 50. Never assign modifier 50 in this case, no way. Instead, you report the primary code for the first artery, and then you report the add-on code 37237 in units for the second artery. Getting this wrong is a critical error that will instantly snag your billing.
Moving right along to Section 4, venous stent codes. We're shifting gears from arteries to veins, which requires a slightly different set of rules. Here's the breakdown. Code 37238 is your primary procedure for the initial vein, and 37239 is your add-on procedure for each additional vein. And just like with our arterial codes, remember that these already include any angioplasty performed within that exact same vessel.
Now, just like the arteries, the veins have a major exception that we need to highlight loudly and clearly. Do not report code 37238 for stent placement within an AV dialysis graft or its draining veins, including central veins, when the placement is performed by going right through the dialysis circuit. If you are working through a dialysis circuit, you're in a completely different coding universe, and you must use AV dialysis graft-specific codes instead.
Now, what's really interesting about this next point is a highly technical alert regarding the tibial peroneal segment. Do not report our venous stent codes 37238 or 37239 if you are also reporting code 0620T for endovascular venous arterialization. This ensures we don't accidentally overlap our standard codes with highly specialized new technology.
Which brings us to a final provocative thought. With so many steps bundled together, strict geographical rules, and distinct anatomical exceptions, are your vascular interventions actually coded to reflect the true scope of the procedure? The real challenge is to apply this structured knowledge to treat the whole patient on paper, ensuring you capture every bit of the physician's hard work without ever double billing the system. Take these mental cheat sheets back to your desk, apply them, and elevate your accuracy. Thanks so much for learning with me on this explainer.